I'm Joe Halko, Director of Community Relations for Northwestern Counseling and Support Services, and welcome to another episode of NCSS Here for You. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community has changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. We take our role in the community seriously and strive to provide a continuum of the highest quality services to meet the needs of individuals who at any point seek assistance. This month's episode is titled Integrative Psychiatry for Mood and Anxiety Disorders, Part 2. Now shortly, we'll be going remotely to a Grand Rounds presentation by NCSS Medical Director Dr. David Mooney. There are some individuals that don't respond well to traditional therapy for depression. However, many times there are nutritional reasons why therapy doesn't work for some people when treating for depression. In today's episode, Dr. David Mooney discusses micronutrients, folate, and vitamin 12 involved in the integrative therapy treatment of depression. Then next month, vitamin D, zinc, and magnesium are among the topics to be covered. So now, let's go to NCSS as Dr. Mooney is ready to begin.
I'm Dr. Mooney. I think all of you know that, but there are some people that are watching this on Zoom, and so they may not have met me. So I'm Dr. Mooney. I'm the medical director here, and I'm pleased to be able to talk about integrative medicine for mood and anxiety disorders today. I think that it's, well, the first thing I need to do is a disclaimer, which is these are not my slides. These slides came from a conference in a couple years ago, 2017, the Integrative Medicine in Mental Health, Dr. Greenblatt's presentation. So they're his slides, but I'm giving the talk. So if it was up to me to make the slides, I'd still be working on them in July. So. Why integrative medicine? Why am I wanting to talk about that? Why am I wanting to practice that? I think for me, having worked many years on inpatient units, at one point in my life I said, boy, this is not working so well for me because I was just seeing all these patients coming in. You all know all about it, the whole circle, and people not getting any better, and I'm thinking there's got to be a way to approach this from a different angle. And so I started checking out some conferences, and the thing that makes integrative medicine work is that we all can diagnose. I consider myself a fairly savvy psychiatrist. I think I can diagnose most disorders and stuff, and I can, well, yeah, you're depressed, and give an antidepressant. Oh, well, good for me. But why? Why are they depressed? We never answer that question. And I think that if we're going to proceed further in this field of psychiatry, I think we need to start answering that question. I think we need to get closer to what our medical colleagues, somehow we've gotten away from the medical model, and I think we need to be more objective, and because that's where we find things. If you don't look, you won't find it. And so in integrative medicine, that involves a lot of metabolic workups, lots of labs. If I take my car to the mechanic, I like to think he looks under the hood. Same thing. We got to look under the hood. So anyways, so this is all you need to know for the test. This is the major pathway here that we're concerned about. I'll be referring to this on and off throughout this whole talk. So Richard Walter studied scurvy, and this slide is in there because he determined that people with scurvy had many different symptoms, and the whole purpose of this is to give you an idea about biochemical individuality. He said scarcely two persons have the same complaints, and basically said there's many differences in how we all present with various different illnesses. He also wrote a book called You Are Extraordinary, which was described ligaments and muscles and joints, and said even though we all share these same parts of our body, everybody's ligaments and all that are different. But it's just a point about we are all different people and about biochemical individuality. Yeah, and this guy does have scurvy, which is also part of this talk. Well, not part of this talk, but obviously, as you know, a vitamin C deficiency. Here's a case, Laura. I think we've all seen similar patients before. Depressed for 10 years, many hospitalizations, strong family history of depression, best of the best at Harvard Medical School. That's who she saw. And she had multiple SSRIs, and as you know, Prozac, Paxil, Zoloft, that group of medications. But, so she's been in and out of the hospital basically for 10 years and depressed and hasn't really gotten any better. So some simple tests were done at that time. The MTHFR is the methyl tetrahydrofolate reductase enzyme. Second is the B12, and then on the bottom is the serotonin transporter. Genetic testing was done, and the MTHFR was a TT. T stands for trouble. Somebody who has genetic testing with a TT on the MTHFR is, no matter how much antidepressant you give this person, Laura, chances are she's not going to get better because she's not methylating. That whole pathway is about methylating. And with the TT variant, it doesn't happen. The serotonin transporter, SS, I think of the S meaning sucks. When you have two S's, that's the same type thing. That means that you've got a kind of a double hit there, and serotonin isn't getting transported across the synapse to the postsynaptic membrane. B12 is low. So my point is, very simple test, and we're able to design a treatment plan for her that allows her to beat her depression, and indeed she did. She was switched to Wellbutrin, which is also kind of common sense, and she'd failed 4 SSRIs, but she was switched to an antidepressant that didn't involve serotonin, and her B12 was increased, and she got better, and she stayed out of the hospital. Another case, this is a very difficult case here, very complicated. This patient had multiple suicide attempts. These are patients that we all know are very hard to work with sometimes, but let's see what happened with her. So, ooh, I got this fancy thing here. Yeah. HPA, that's a metabolite of Clostridium. That was elevated in her urine. Vitamin D is low, B12 is low, and all her omega-3s are low, which you get from fish oil. So simple solution for her. She was started on B12, D3, omega-3, zinc, vitamin C probiotic, and got better. So point is, there are alternative ways to approach this that are very effective. This is Dr. Greenblatt's ZEEBRA approach, and he has outlined this with different approaches for treating depression and anxiety. And we're going to focus on Exclude right now. So when we talk about excluding things, one illness that involves excluding is celiac disease. So in this patient, not this patient, but so celiac disease presents sometimes before people even have the physical manifestations of celiac disease. They'll present with fatigue, depression, and anxiety. Schizophrenia is on there. That's quite a leap, but I'm not going to argue it. But anyways, they often present with those symptoms. But the thing about celiac disease is it's a fast track to malnutrition. And if you're malnourished and you aren't getting these nutrients, then that pathway at the beginning of the talk that we talked about doesn't get completed. So you aren't getting the neurotransmitters that you need. So, yeah, that's celiac. And these are the deficiencies in celiac disease. The point is, when you're deficient in all these vitamins and minerals, you can't complete that pathway to the neurotransmitters. The transmitters are not getting synthesized. Therefore, that's why you're depressed, anxious, tired. Same thing with bariatric surgery. It's bariatric surgery has been a good thing, but unlike celiac disease, where the intestinal wall is getting destroyed, we're removing part of the gut here, and so again, all the nutrients aren't getting absorbed, like what happens in celiac disease. So you're missing all these precursors that we need to develop neurotransmitters. Bariatric surgery, as you know, gets quite complicated. People do bariatric surgery. They're often very pleased with their results, but it's very hard for them to follow through with what they need, which is usually B12 shots, vitamins, minerals, and it's a hard thing for people to continue to do, and they need to keep up on those, or often they develop depression and suicide. They're also hesitant to go back to the surgeon because they've been through a lot. But again, the point is malabsorption, not getting the nutrients that you need. Pellagra, this is on here just because it's interesting. Most people haven't heard of it. This is an example of a B3 deficiency, and this was common in the early 90s. These, I don't know if it's pellagrans or pellagrans, but I think it's pellagrans. So in the South, where people eat lots of corn and don't get a lot of B3, there were hospitals filling up with pellagrans. And because they weren't getting the B3, they were developing symptoms like schizophrenia. They were becoming psychotic. They were delusional, and one way that they treated these pellagrans was they gave them brewer's yeast when they were in the hospital, and brewer's yeast is just loaded with B3, so that's what they used to treat them. But that's kind of interesting. But anyway, so celiac disease, bariatric surgery, pellagra. These are 3 examples of diseases that, where abnormalities of absorption result in mental illness. So that's the point there. Oh, these are the pellagrans here. Pretty sick-looking bunch. Yeah. Right here, Dr. Hoffer. Dr. Hoffer was like he started orthomolecular medicine, and he was actually one of the people that started working with these pellagrans, and he demonstrated the concept of vitamin dependency. These are Canadian prisoners of war, by the way. He developed a plan whereby he was treating them with, I mentioned the brewer's yeast, but he was treating them in general with high doses of vitamin B3, and they did well, and their symptoms didn't come back. Yeah. Linus Pauling was in that same thing, the orthomolecular school, and orthomolecular psychiatry was around a long time ago, but it was kind of sort of a precursor to integrative medicine. As you can see, it says varying the connections of substances normally present in the human body may control mental disease, and that's the whole point, using our own health as it is and making it as good as it can possibly be, maximizing our physical potential through what's already there, adding to it with supplements and stuff. Yeah. Yeah. Not this guy, but the other guy. Hoffer, the orthomolecular guy, in 1972, he went to the American Psychiatric Association and he tried to present his paper on treating these pellagrans with vitamin D, because they were a lot of them were psychotic and stuff. And the story goes that he was laughed out of the meeting because they thought his ideas were just bizarre and didn't make much sense. But that was 1972, and in 1972, homosexuality was still a DSM diagnosis, so it kind of gives you an idea how their thinking was at that time. You know, they weren't open to much change or different ideas. So folate. Low folate is associated with increased incidence of depression, poor response to antidepressants, people relapse quicker, and there's lots of evidence supporting the relationship between folate and depression. A lot of these are in here because there's lots of research on this stuff, and I think people need to know that. Oftentimes they think there isn't, but this is the Journal of Psychiatric Research, well-known journal, and this also talks about there being lower levels of folate and dietary folate in depression. Relapse rates. Treat somebody with Prozac for 28 weeks, which is a reasonable trial of Prozac or fluoxetine, and those with low levels, 43%, that's a pretty high number. Those 43%, if their folate levels were low, would relapse. Normal folate levels were only 3%. What causes folate deficiency? A lot of the drugs we use, especially valproate or Depakote, that's a big culprit. A lot of chronic illnesses, diabetes, Crohn's, renal failure, hypothyroidism, lifestyle things, smoking, drinking, poor nutrition, aging, L-methylfolate, which is the methylated form of folate that we need in the brain that decreases with age, and this genetic polymorphism, which I'll talk about a little bit later, the CT. There's both a CT and a TT polymorphism and a body mass index over 30. Those are about folate deficiency. When you test for folate, if you test for folate, oftentimes it's falsely elevated, and that's because our food is fortified with folic acid. Like you think of all the cereals that have folic acid in them. So if you think of the pool of folate in your blood, in your body, a lot of that is folic acid. And that's important because you're not getting an accurate reading of the folate because what's important is the folate which goes into across the blood-brain barrier. The folic acid just kind of adds to the pool. And this is about people with depression, and again, showing a better response with folate than without it. Yeah, this is what I was just talking about. This is the end product here. This is L-methylfolate. This is the only thing that crosses the blood-brain barrier. This is what you need. This is what you benefit from. All this is when you have synthetic folic acid in the blood, these are the different metabolites that get to this pathway here. So folate levels are high because of all of this, but that's really all that matters there. This is what I talked about at the beginning about the genetic testing. So there's different polymorphisms here. TT is for trouble. Basically, if you have that MTHFR TT polymorphism, that means that you are not a methylator. Like I said before, that means you are not going to respond well to antidepressants. Okay? CC, if you want to look at it this way, the CC polymorphism genetically is like the best scenario. That means you have a better chance of responding to antidepressants because you're going to be a better methylator. And this is kind of in between, CT. Yeah. When you combine these, you can see like the CT, T again is for trouble. That's the one that's most likely to cause you problems with not methylating. And you can see there's a higher reduction in activity than with the C allele, which is just a 20% reduction in activity. Inflammation is everywhere, and inflammation just stresses the system, and inflammation takes away from L-methylfolate and takes it down different pathways than where it needs to go. Yeah. Any oxidative stress, anything causes inflammation nowadays. Okay. This is a really confusing chart. Makes me look smart to put it up there, but I don't really know much about it. So the bottom line is you got your folate deficiency up there. We go through all these different pathways to get to the CNS disorders in the brain, and they're all the result of low CNS, again, 5-methyl tetrahydrofolate, which is the key component for that. I'm not sure why this is in here, except maybe for reassurance. Prevention, early detection, and management of this reversible B12 deficiency state is of profound importance. Somebody said that. This is what happens with B12 deficiencies, various illnesses here, including sometimes even like B12 deficiency can lead to symptoms of OCD, can lead to more generalized anxiety. There's even been some cases of mania in adolescents with vitamin B12 deficiency. Psychotic depression with vitamin B12 deficiency, a very important thing to check for. This is just a chart that talks about how these male patients didn't respond to 3 trials of antidepressants. They were vegetarians with low vitamin B12 levels. Again, supplement with B12, and there was improvement within a month. So that's the thing on B12 and resistant depression. Again, lower levels of B12 associated with higher scores on the Beck Depression Inventory, and lower efficacy of Prozac for depression, which is what we've been talking about. These medications don't work well if you aren't methylating, and if you don't have these nutrients to base that pathway, and a poorer response. Prevention in the elderly, this has actually become fairly common. A lot of geriatricians are giving more B12 and for depression, and likely not to develop depression during that time. So there is a prevention model as well, not just treatment. Again, prevention in the elderly, maybe protective over time. Yeah, same thing, just more and more evidence. And if you want to know about these journals later, I'm happy to let you know about them so you can read up on some of this stuff. Yeah. So there's some talk that why not just take vitamin B12? You know, there's these people with deficiencies, and why don't we just take it regularly? Well, we probably should. That's certainly something that we would benefit. You usually don't need, if you eat a normal diet and you're eating meat, certainly with meat you're getting B12, but most people really don't need to be supplemented. But back many years ago, I think GPs used to give B12 shots just because people were not having enough energy or something, which is fine, it makes sense, totally harmless. But I think for most of us nowadays, we probably eat pretty well. But again, if you have some malabsorption syndrome, if you've got celiac, if you're not absorbing these nutrients, it doesn't matter. Cryptopyrroles. So if you go back to that chart at the beginning, vitamin B6 and zinc are very important cofactors on that pathway to neurotransmitter synthesis. So there is a very easy test you can do in urine for cryptopyrroles. Cryptopyrroles basically glump up the B6 and the zinc so they can't be used. Very simple explanation, but that's it. So they're non-functional. So now you got no B6 or zinc. See this pathway here? And B6 and zinc, because they've all kind of clumped up in this cryptopyrrole thing, and it's called Pyroluria. And that's important. Again, these are all really simple tests, and you can very simple to test for. You get a urine, you check for cryptopyrroles. You have cryptopyrroles, you know they're binding B6 and zinc, and so you give them more B6 and zinc, and it makes this pathway complete. Symptoms of pyroluria are from the deficient B6 and zinc, depression being one of them, and mood swings and all these psychiatric symptoms. Yeah, not much more to say. So you just treat that with B6 and zinc, and they usually improve fairly quickly. And usually, like if you were giving B6, like the kids I see, I give all my kids B6, and typically they have doses of 25 or 50. These are the high doses of B6 for that pyroluria. You have to be careful with B6 because you can get neuropathies in higher doses. Zinc, that's replaced at that level. People don't believe this. People think vitamin D is just nothing, but it's really important. And as you can see, it causes depression. There are cases where it's caused schizophrenia, and it can be used for Alzheimer's. More kind of preventative in the early stages of Alzheimer's than for actually treating Alzheimer's. But it's probably one of the most important, vitamins. Another chart to make me look smart. All that matters is this. We know that everything goes to serotonin, which is involved, which is the neurotransporter we want for depression and all that. But the key piece here is this this enzyme here, TPH, which requires folate. That we're talking, all the stuff we're talking about as a cofactor for tryptophan to be converted into 5-HTP. But vitamin D is the cofactor there. And that's important for that to move forward, because if that doesn't move forward, then you aren't getting to serotonin. Okay. This is a little bit confusing, but so vitamin D works on tryptophan hydroxylase 2 in your brain to increase the levels of serotonin. That's good. That helps with depression, with moods, with anxiety, with sleep. Vitamin D acts on tryptophan hydroxylase 1 in your gut, in the serotonin in your gut, where most of your serotonin is, and it suppresses that. That's good because that reduces inflammation. So, the interesting thing is vitamin D is doing two things in two different parts of your body, both of them good, if you have enough of it. If you've got enough vitamin D, it's working in your brain to increase the serotonin. That's good. It's working in your gut to reduce serotonin and thus reduce inflammation. If you don't have enough, then it's going the other way. If you're low in vitamin D, then you aren't making serotonin in your brain, setting up depression, mood disorders, anxiety. Also, you aren't suppressing serotonin production in your gut, so that sets up inflammation. Now, this is basically what I just talked about, but this is up here because it talks about the importance of vitamin D prenatally. So prenatally, or at any time, doesn't have to be just prenatally, but so you get, if vitamin D is low, that TPH2 that I'm talking about is not, is reduced, the activity is reduced, so you have reduced brain serotonin synthesis and abnormal brain development. That's kind of important. With adults, still important because, like I said, the serotonin isn't made as it should be. And then going along with that, back to the gut, when it's low, you have increased, you aren't tweaking TPH1, you have increased serotonin in the GI cells, and that results in increased inflammation. Okay. So tryptophan, which we just talked about, tryptophan goes to 5-HTP, has to cross the blood-brain barrier. You need vitamin D for that to happen, as well as other parts of this.
I want to thank my guest, Dr. David Mooney, for sharing his insights on the benefits of integrative psychiatry for mood and anxiety disorders. Next month, we'll continue the discussion about vitamin D, along with zinc and magnesium, among other topics relating to the treatment of depression. I also want to thank you, the viewer, for spending time with us again this month. You can learn more about NCSS programs and services by visiting ncssinc.org. I'm Joe Halco, and I'll be back next month with another episode of NCSS Here for You.